This is Eyes Balls by Angela Keene and Katie Trefko. We will be talking about ocular emergencies in the ED using ultrasound. The clinical indications for ultrasound of the eye in the emergency department include eye trauma, acute change in vision, headache, head trauma, and altered mental status. The most common presentation for a vision-threatening injury is blindness after the injury, but vision loss can be gradual because of unrecognized trauma or the inability to report vision loss because of lid swelling or mental status. Pelletier et al. Performed a retrospective review of trauma patients with potential ocular injury, and they demonstrated that non-ophthalmologists frequently missed or underestimated potential eye trauma, missing 28% and only referring 27% for ophthalmologic evaluation. Grossman et al. Looked at the incidence of facial fractures with concomitant ocular injury, and with 283 patients, they found that 71 had ocular injury and 32 with serious injury. The reason why I mention these studies is because in these cases, ultrasound could be of useful diagnostic value.
Identifiable pathology using ultrasound can be vitreous detachment, retinal detachment, vitreous hemorrhage, foreign bodies, lens dislocation, globe rupture, retrobulbar hematoma, elevated ICP, and choroidal detachment. No other imaging modality can reliably ascertain anatomic position of the retina, just as a side note.
Contraindications to using ocular ultrasound: obvious or suspected globe rupture, significant periorbital injuries, suspected clinically significant retrobulbar hematoma. If pressure of the injured eye would be detrimental, because if done properly, no pressure should be applied directly to the orbit, but in these cases, pressure would increase the chance of further vision loss.
Going over anatomy real quick, the eye is a fluid-filled structure and therefore provides a perfect acoustic window for ultrasounding. The normal eye is a circular hypoechoic structure. The cornea is seen as a thin hypoechoic layer parallel to the eyelid. The anterior chamber is filled with anechoic fluid and is bordered by the cornea, the iris, and the anterior reflection of the lens capsule. The iris and the ciliary body are seen as echogenic linear structures extending from the peripheral globe towards the lens. The lens itself is anechoic. The vitreous chamber is filled with anechoic fluid. On ultrasound, the normal retina cannot be differentiated from the other choroidal layers. The retrobulbar area includes the optic nerve, the extraocular muscles, and the bony orbit. The optic nerve is visible posteriorly as a hypoechoic linear region going away from the globe. Facial bones obviously are bright reflections with deep posterior shadowing. The lid is echogenic and divided by hypoechoic tarsal plates. The anterior segment includes the cornea, the anterior chamber, the iris, the posterior chamber, and the lens. The posterior segment includes the vitreous chamber, the retina, the choroid, and the optic nerve, which represents 80% of the globe. The ophthalmic artery runs parallel to the optic nerve, and the central retinal artery and vein are located in the posterior part of the optic nerve shadow.
Technique. For ocular ultrasound, high-resolution transducer should be used. The eye should be closed, a tegaderm can be placed over the eye, and a large amount of water-soluble gel should be placed on top. The view should be sagittal and transverse, and the patient is instructed to look ahead and not to clench eyelids. You should create a pillow of gel, and during examination, adjust gain up and down over a wide range to eliminate artifact and identify subtle findings. The ultrasound technique involves suspending the transducer over the bed of gel to try to avoid putting compression on the globe. You should be adjusting the gain several times through the examination. If too high, you will get artifact, and gain too low can cause you to miss something such as a small vitreous hemorrhage. Both transverse and longitudinal images are necessary for adequate examination. The iris and an anterior chamber evaluation ask the patient to look superiorly and place transducer on the inferior portion of the globe in transverse. Sweep the image sector cephalad to acquire the frontal plane of the iris and pupil. You can measure pupil size by shining light in an uninjured eye. A hyphema or hypopyon might show an area of echogenicity in the area of the aqueous humor.
Now going through our pathology. Vitreous detachment. This is a hyperechoic linear density that you will see in the posterior chamber. It occurs in the front of the optic nerve, and you may have to increase gain settings to actually see it. You often see a C-shaped concave upward appearance sonographically. The membrane may appear jiggly with eye movement, and it's thinner than a retinal detachment. And it is not attached at the margins of the optic disc. The retinal detachment remains anchored at the optic nerve.
Retinal detachment. Fluid enters the potential space beneath the retina. It is seen as a hyperechoic undulating membrane in the posterior to lateral globe, and you are looking for a thick hyperechoic membrane. The normal retina is continuous with the other posterior elements of the globe. A retinal detachment can be accompanied by a vitreous hemorrhage. Retinal tears are difficult to see unless they are substantial. When visualized, they are short, reflective linear structures protruding into the vitreous. Subretinal fluid is another clue that there is a tear. Retinal detachments appear as highly reflective membrane, which seems to float in the vitreous, which are mobile with eye movements. The movement decreases as the detachment ages and it becomes slightly thickened. With complete detachment, a connection to the ora serrata is maintained anteriorly as well as posteriorly to the optic disc, giving the membrane a V-funnel shape within the vitreous cavity. This is a video of retinal detachment. As you can see, the flap undulating.
Vitreous hemorrhage. This is something that can interfere with vision and cause blindness. It appears as an echogenetic material in the posterior chamber. If it's new, you're going to see small dots or linear areas of low reflective mobile opacities. But as it ages, the blood is going to organize layer dependently due to gravity and forms membranes. This is a video of that.
Ocular foreign bodies can be identified using ultrasound. They will be hyperechoic with either shadowing or reverberation artifact in the vitreous. Patterns of shadowing or reverberation may give information about material. They typically appear as highly refractive objects that may be located in the vitreous, the retina, or the posterior orbital fat. If embedded in the fat, it may be missed because of other highly echogenic structures. If highly reflective, it will produce a twinkling artifact with color Doppler, which is a rapid changing mixture of red and blue. This is a video of an ocular foreign body. And this shows the usefulness of ultrasound. It is an 8-year-old boy who is refusing to open his eyes, so you would be unable to identify by direct visualization.
With a lens dislocation, you're going to see a hyperechoic disc-shaped lens floating in the vitreous. It can be partial, which is a subluxation, or complete. In a subluxation, the lens may appear normal, but with eye movement, it may appear to move independently of surrounding structures. With a complete dislocation, it may be more obvious with the lens out of its usual position all the time.
Globe perforation or rupture is considered an ophthalmologic emergency. It requires surgical intervention and involves a decrease in the size of the globe, an anterior chamber collapse, and buckling of the sclera. Evaluation by ultrasound is of value when abnormalities like corneal edema, hyphema, vitreous hemorrhage, or cataract make direct visualization of the ocular contents difficult. Globe perforation, sonographically, the globe may be decreased in size, You may see buckling of the sclera posteriorly, and vitreous hemorrhage is frequently present. Close evaluation of the anterior chamber is warranted, as it may collapse from a small perforation. Use tons of gel as to not make it worse. No pressure when you're doing ocular ultrasound.
With a retrobulbar hematoma, you're going to see a hypoechoic collection posterior to the globe. It may displace the optic nerve. This is usually something that occurs with a trauma. The patient may have a loss of vision. You're going to see an echolucency just posterior to the globe, and since the orbit is a closed space, the pressure may be exerted on the posterior globe by the hematoma. This pressure sonographically shows it as a distortion of the posterior aspect of the eye. Changes in the spectral Doppler pattern of the retinal vessels may also be seen. The hemorrhage may actually be difficult to identify because the blood may be isoechoic to the other posterior structures. The retrobulbar hematoma can be diagnosed clinically when significant hematoma is present, but keep in mind, in trauma victims with decreased level of consciousness, it often goes unrecognized, leading to a possible delayed diagnosis, which may result in irreversible damage to the optic nerve and blindness.
Elevated intracranial pressure can be identified using ocular ultrasound. The optic nerve sheath measurement can give you an idea whether or not there is an increased ICP. Reasons why you would have elevated ICP include head injury, spontaneous intracranial bleed, etc. Papilledema may be delayed after ICP elevation by several hours. The optic sheath attaches to the globe posteriorly. Optic nerve sheath diameter and ICP is a well-established correlation. In patients with altered level of consciousness, they may be suffering from elevated intracranial pressure. On ultrasound, the sheath contains fluid. When evaluating for diameter measurement, it is made 3 millimeters posterior to the optic disc. The max measurement will vary with age. Greater than 15 years old, 5 millimeters. 1 year old to 15 years old, 4.5 millimeters. And less than 1 year old, 4 millimeters. Increasing diameter correlates well with increased ICP measurements, typically plateau at 7.5 millimeters. If elevated for a significant amount of time, you can see an echolucent circle within the optic nerve sheath separating the sheath from the nerve, and this is called the crescent sign, and is a corollary to fundoscopic papilledema. There is no proportion with the increased diameter with ICP. Crescent sign common in conditions such as pseudotumor cerebri.
In this picture, you're seeing a dilated optic nerve sheath measuring 5.3 millimeters in a patient with increased ICP. Okay, choroidal detachment. This is a separation of the choroid from the sclera due to blood accumulation from ruptured vessels. This is when the smooth dome-shaped thick structures are separated from the posterior aspect of the eye.
If they become big enough to touch the vitreous, it's referred to as the kiss. The choroid itself does not display motion with the eye movement.
Pitfalls of ultrasound. The transducer should only touch the gel when a ruptured globe is possible. Absolutely no pressure should be put on the globe itself. Over-reliance on ultrasound when worrisome symptoms or exam findings are present can cause you to have a misdiagnosis. Misjudging artifacts or subtle abnormalities due to improper gain settings can cause you also to have a misdiagnosis.
So that's why it's recommended to change gain settings to evaluate if you have a finding to see if it's present when the gain is high or low. We hope you enjoyed our presentation. The information gathered was from Ma and Matier's Emergency Ultrasound 3rd edition in the ocular section. Thank you.
Thank you.